Hello, everyone. Welcome to Tuesday Night Rheumatology. It's Tuesday, 30th of April, 2024. This is the last in a series of replay webinars focusing on the sessions from RheumNow Live 2024 in late January. Prior to today, we covered RA, PSA, SPA, and vasculitis. And tonight, we're going to be talking about the mastery of SLE. This is a really good session. We have three really tight lectures on really topics that I think are cutting edge in lupus. Specifically, we're featuring Dr. David Karp talking about rethinking preclinical lupus. Then Michelle Kahlenberg talking about the lupus flare and the biology behind the flare. And then lastly, Andrea Fava from Hopkins talking about biomarkers in lupus, the future of more accurate and usable assessments. So we'll begin with rethinking preclinical lupus and Dr. David Karp, who is the chairman of the Department of Rheumatic Disease Division at UT Southwestern. He's a professor of medicine, a good friend, fabulous teacher, great researcher, past president of the ACR. And in the beginning of his talk, he goes over, why we need to understand lupus before it happens. It's not as easy as an ANA negative consult goodbye, ANA positive consult and goodbye, but that we do need to think about how to identify patients at risk, making early interventions that might make sense. And he's going to get into his nomenclature and staging system for these patients and some of the thoughts behind why intervention might make great sense. So let's begin with Dr. Karp, already starting his lecture.
Cytokine therapies. So I want you to, if you don't remember anything from this talk, just remember this figure that I think in order to prevent disease with those different kinds of with primary, secondary, and tertiary prevention, what we need to do is be able to define the stages of disease. Okay, and many of us are in rheumatology thinking about prevention, are thinking about these transition points or these stages of disease. So let me just walk you through this. Pre-stage 1, this is our healthy population, but people can be at risk due to their genetics, their environment. But there's no evidence of cellular or humoral autoreactivity in those individuals. No positive ANAs. If you could look at their T cells, there's no responses. Their cytokine levels are normal. Then there's a hard transition, and I indicated that by the dark black line, to stage 1, where there's evidence of autoimmunity, but there's no symptoms. These are people who have a positive ANA, for example, because that's what we can measure easily, or other autoantibodies if you measure those, and if you could in the research lab measure self-reactive T cells and maybe elevated soluble mediators like cytokines and chemokines. Then stage 2 is when we see expanding autoreactivity, more of those same autoantibodies and soluble mediators, and maybe a few symptoms. And stage 3 is where we have classifiable disease. In stage 2, the transition from 1 to 2 and 2 to 3, I've indicated by a gray bar there, because we're really not sure what's going on at those stages and how to define them. And I think that's an area of great need. And if you see in stages 1 and early stage 2, patients have people, they're not yet patients, have no health concerns other than maybe trying to explain an abnormal lab, but they don't need treatment. And after that, they have health concerns and they need treatment. So it's at these earlier stages where we have the potential for disease prevention. So why have these diagnostic stages instead of just calling them preclinical lupus, preclinical RA, preclinical scleroderma? I think that it's very helpful if we could do this, and I think that's a big if, it's a big lift, but if we can do this, it avoids this semantic controversy where you have clinically suspect arthralgia, pre-RA, or in incomplete lupus or pre-lupus or form frustive lupus or undifferentiated connective tissue disease, my favorite wastebasket. So we've all probably used these terms and used them with our own individual definitions, and that's the problem. Even if you read the literature, you find out that different investigators use different definitions for these terms. But instead, if we have the right definitions, we can say to the patient, you have stage 1 lupus, and this is your risk of progressing to stage 2 or stage 3. And this is what we need to do, or we need to do nothing. But that requires that we have a high specificity definition. And I say it has to be one that we all agree on. And when I say lupus and we all agree on in the same sentence, that's kind of ironic at the very least. But it avoids diagnosing and treating the wrong people. And the benefit here for patients is that they get a diagnosis sooner. We know that lupus patients spend 3 to 5 years searching for diagnoses. And some of that is them and some of that is us. But both together, it's a problem. So we need a clear path to their diagnosis, and we need a clear path for research in disease progression and regulatory approval of any potential therapies. An example here is type 1 diabetes, where they are 20 years ahead of us here in type 1 diabetes. It's an easier disease because it affects only one organ, if you will. But stage 1 diabetes, as they've defined it, are people with islet-specific autoantibodies, and they have a defined probability of developing clinically evident type 1 diabetes. Stage 2 are more autoantibodies plus beta cell dysfunction. But still asymptomatic. Stage 3 would be symptomatic type 1 diabetes. And based on these definitions and the research that went behind them, the FDA they've done a clinical trial with an anti-CD3 monoclonal antibody, and the FDA has approved this over a year ago. That delays the median time of onset of type 1 diabetes by about 30 months. And this is very similar to the data that Hani showed us this morning in rheumatoid arthritis. It's not clear whether delay is good enough or whether multiple infusions of this will actually cure or prevent the disease, but it's a start. So what does this look like for lupus? And as Hani said, we all have this kind of a figure. This figure got me 2 $6 million grants from the NIH, so I think it's a pretty good figure. So you start out with people who are not at risk, and then a small group who are at risk of developing lupus. You have stage 1, which is altered immunity, the positive autoantibodies and soluble mediators. Stage 2, I've labeled it incomplete lupus, and I can argue that I'd like to just change that to stage 2, but we're calling it incomplete lupus for now. And this means people who have these autoantibodies and soluble mediators plus something else, and whether that's leukopenia, thrombocytopenia, or isolated skin disease, or a few involved joints, that's what we have defined it as. And then stage 3 would be what we are currently using, are classifying as disease with multiple criteria. And again, we can argue about whether our classification scheme that's based on clinical criteria is as good as molecular criteria, but this is where we are now. Stage 4, I would say, would be irreversible tissue damage. And again, stages 1 and 2 offer us a window for screening and prevention. So here's an example of what this kind of looks like. Where do we have evidence that this is the case? This is from our group here at UT Southwestern, where we have a microarray, a chip that will allow us to quantify autoantibodies to over 100 autoantigens at one time. And if you look at healthy individuals on the left in the green there, they don't have a positive ANA and they don't have any autoantibodies. But healthy individuals who are ANA positive start to make autoantibodies to a lot of different things. Not just the nuclear antigens, but other antigens in the skin, in the thyroid gland, in the liver. As those patients progress to have symptoms, a few symptoms, but don't classify as having lupus, there are more autoantibodies present, primarily in those non-nuclear antigen-rich fraction. And then as they are classified as having lupus, we have a larger increase in autoantibodies in both the nuclear antigen-rich and non-nuclear antigen-rich clusters. So again, this spreading humoral autoimmunity as part of the process of going from healthy to classifiable disease. And the group in Oklahoma, our collaborators at the Oklahoma Medical Research Foundation, Judith James and her colleagues, have studied this for many years, for at least 20 years now, looking at not just autoantibodies as spreading prior to the development of SLE, but soluble mediators such as TH1, TH2, type 1 interferon regulated mediators. And you can see that there's a temporal association here with Th2 and Th17 cytokines beginning to rise in individuals 6 to 7 years before the diagnosis or classification of lupus. Th1 cytokines a little bit later, and then autoantibodies that are specific for SLE in the year or two prior to diagnosis. So if we want to try and look at preventing lupus at the earliest time point, we have to do something other than just look for autoantibodies. And their group has combined autoantibodies with soluble mediators and to create a scoring system that I believe will be commercially available sometime soon. But this scoring system looked at, again, individuals in their military cohort that went from being pre-criteria, which by them meant just having some of these soluble mediators and autoantibodies, to being incomplete lupus to having lupus. And you see in the top left there, the control group, the healthy individuals, had a negative number, and the individuals, as they progressed through these different stages of lupus, 1, 2, and 3, their score here goes up. So this is all retrospective, and allows us to say that this scoring system could effectively sort people into these categories. It doesn't tell us whether we can predict that. But again, it's a start. It's a way that we can identify individuals who may be on their path to developing lupus. So what are the questions we have here for stage 1? What biomarker changes are specific for lupus? It's clearly not an ANA, we know that. But are there others that are specific for lupus that would tell us that the patient is going to develop SLE versus scleroderma versus dermatomyositis, for example? We don't know how many progress to stage 2 or beyond. Again, these are all, we've done this all with retrospective studies, and prospective studies are needed. Can they revert? Can somebody develop these biomarkers and then go back to having a pre-stage 1 phenotype? Can you prevent that? And who should we screen? You know, I don't know that we want to say that if we had a screening test for lupus, we want to apply it to every 16 or 20-year-old girl in America, or to be fair, everyone. But we know that lupus is 10 times more common in women. But I think that we need to know the characteristics of the test first. Oops. Okay. What about stage 2? And I've talked about incomplete lupus as stage 2, and I've defined that as this a few features of lupus, but not enough to be classified. And the term incomplete lupus was coined by Panish's group in the late 1980s. And over this time period, it's really meant somebody who has an ANA plus 1 or 2 criteria. And beyond that, it's not well defined. And in fact, if you look at cohorts of people who are called incomplete lupus, they have varying amounts of the criteria that we think of in the lupus literature. 9 to 46% of patients in different cohorts have rashes. 11 to 53 have arthritis or synovitis, serositis. You see hematologic findings. Again, just to show that all of the features that we think of in lupus are present in incomplete lupus, and there's nothing clinically that defines that. And how many of these patients go on from incomplete lupus to complete lupus? And these are I just picked out 4 studies. The top one is one that Nancy Olson and I did here at UT Southwestern in a small cohort. We had 3 of 22 ILE patients became lupus over 2 years with some autoantibodies that predicted that. The Harvard group, the Brigham, 56 of 264 patients over a 6-year time period. And again, some autoantibodies predicted that. Vicki Worth's cutaneous lupus cohort at Penn, 13 of 77 lupus patients over 8 years. And then a Spanish cohort had about a little less than 10% of patients over a 2-year period. And in general, 2 to 5% of patients who have ILE will develop lupus per year. So, the questions that we have to think about with this quote stage 2 is, how do we define it? Are we going to define it clinically, as I've just mentioned, as somebody who has a little bit of rash, a little bit of joints, a little bit of blood abnormalities, or do we have a molecular definition, or do we need to use both? How often does it progress to stage 3 at classifiable lupus? Are there more than one stage 2 phenotype? Is there a stage 2 phenotype that goes from to lupus nephritis, or a stage 2 phenotype that goes to lupus with skin and joint disease? And again, the important question is, can we prevent that? And if we do, what do we prevent it with? So here's one example of how you can do this. This is a study that I've been involved with. We call it SMILE, the study of antimalarials and incomplete lupus erythematosus, where we took patients with ILE and randomized them to either hydroxychloroquine or placebo and followed them up over 2 years. Here's a clue. If you're going to do a 5-year clinical trial and clinical study, don't do it when there's going to be a global pandemic and turn it into a 7-year study. So I can't tell you the end result yet. I can't tell you whether hydroxychloroquine prevents lupus in these patients. I will be able to tell you that later this year. But then we also have blood samples from these people as well as clinical data, and we're going to be following that for the next 5 years to be doing some really in-depth study of the immune system in these people. And this is how I think about this, for what needs to be done, not just with our study, but with other studies, that we look at these real-world undiagnosed patients, record their therapeutic responses, and then assess the utility of common in these novel biomarkers.
Okay. So thank you, Dr. Karp. I thought that was he sort of ends up with what else does this mean and where else can we intercede and whatnot, but I think that you got the gist of what he's saying. The interesting thing is that this is going forward, that people are looking at these, the progression to lupus. And this impacts us because we're seeing tons of the ANA consult. And often the ANA was done because of a clinical reason, either because of a symptom or another test. And all of you would probably say, none of those ANA positive consults ever turn into anything. I would say, based on my research and doing some microarrays on people with just ANAs, that at least 1 in 20 or 1 in 10 has got something going on immunologically. And then Dr. Karp showed evidence that it's, 1 in 6, 1 in 5, 1 in 10. And the idea is, who should we be following and when should we bring them back in? And I think you have to give them rules, right? That's all what patients want. They want hope, goals, and rules. I want to encourage you to ask questions. Put your questions in the Q&A box, and we'll address them here. At the end of these presentations, we'll go over the questions from this week's survey with almost 200 of you answering questions on lupus. Our next speaker is Michelle Kahlenberg, a fabulous researcher, clinician, and leader from the University of Michigan. Michelle has a long career working in lupus. I just dreamed up this topic that said, what if someone could address the issue of, flares in lupus and what's really behind it? What's the biology behind it? And that's what I presented to her, and she said, fine, I'll do it. That almost never happens when I come up with my crazy wishes for titles. And she did do, I think, a fabulous lecture. I want you to know that I'm cutting this off. I'm giving you about 15 minutes of a 33-minute lecture. If you want to see the whole lecture, you can see the video. It's on RheumNow and it's on our YouTube channel. YouTube, look up RheumNow, and you can consume all of her lecture where she goes really deep into explaining the biology of the flare and the mechanisms. She goes into what the potential ramifications of this are. And she ultimately ends up with another 15-minute lecture on the EULAR guidelines for the treatment of SLE. And I think that in itself is also wickedly informative. So let's get to Michelle's lecture again on the biology and treatment of flares in systemic lupus.
So to start, I thought I would remind us about the cycle of lupus. So we think that lupus initiates from genetic predisposition that interacts with environmental triggers. And over time, this results in innate immune activation that then educates our adaptive immune system to promote the development of autoreactive B and T cells. And these B and T cells, the B cells contribute to immune autoantibodies, and these can lead to immune complex formation, which can then deposit in the tissue. And we may not see disease initially, but the cycle can repeat, and eventually we will get to clinical disease onset. And one of the things to remember is that the presence of these autoantibodies often occurs way before a patient ever presents with a phenotype that looks like lupus. And so really having the autoantibodies themselves isn't enough to actually cause lupus, and it's probably this interaction with the environment over time that promotes and drives the actual presentation of disease. So when we think about a lupus flare, we know that about 25% of patients per year will have a flare of their disease. And how we quantify this, I think, is up for debate. There's several different ways you can measure disease activity in lupus, including looking at the sleeve-slidi or the BILAG, and there's flare definitions within each of these metrics. There's the sleeve-slidi flare index. But for me, I think the most useful definition of a flare is really, does the patient feel worse? And do they feel worse because it's their lupus? And so one of the things as clinicians that we have to do is really figure out if their change in symptoms is related to lupus itself, or whether there are other diseases that can be contributing to them feeling poorly. And I think fibromyalgia is one that we often see overlapping with lupus. And so is there complaints of pain or fatigue more related to a fibromyalgia type reason than active lupus? Stress is certainly a known trigger for lupus flares, but being stressed out can also make people feel more pain, sleep poorly, in general feel terrible. So this could be a contributor or mimic. Infection is definitely one that can cause symptoms that can look like a lupus flare. Lack of sleep, when patients don't sleep, they feel worse. And so sometimes they can have pain and other symptoms like worsening fatigue that could be because of poor sleep instead of their active lupus. Also, other treatable medical issues like iron deficiency, vitamin D deficiency, concomitant autoimmune diseases like celiac or hypothyroidism. These things can all make patients feel terrible. And so, as rheumatologists, one of the things that we pride ourselves on being really good at is investigating and understanding, all of the systems that can be involved in autoimmune disease, but that can also contribute to a patient feeling unwell. So if we do our detective work and we decide that a patient actually does have increased lupus activity, what do we do once we reach that conclusion? And I think the most important thing for us to really figure out how to properly treat our patients is to understand the underpinnings of lupus, to really know which drug we need to pick. And so I'm going to try to talk about the biology of lupus and lupus flares in about 5 slides. We'll see. So I think the first thing to remember is that lupus flares require a trigger. There's usually something that pushes people over the edge. And the reason that these triggers actually can cause a lupus flare is really the interaction with the innate immune system. So a lot of the known triggers for lupus, like sunlight, infection, stress, diet, these all have impacts on the macrophages and dendritic cells that are living in the tissues of these patients. And these macrophages and dendritic cells then make pro-inflammatory cytokines, and they also present antigen to T cells and can turn them on and activate T cells. The other thing is that if you already have some autoantibodies floating around and you get some immune complexes formed, even if you don't feel sick, these immune complexes can also activate our macrophages and dendritic cells and turn them on and sort of start this flare process as well. And then again, the downstream consequence of these macrophages and dendritic cells getting turned on is the activation of B and T cells. So I always feel that the innate immune system is really important in initiating the trigger of a flare. The second point, I think, is that type 1 interferons are really a unique lupus feature that impacts disease. And this is some older data shown here, where they just looked at how much type 1 interferon bioactivity is in the serum of patients with different autoimmune diseases, including lupus, Sjogren's syndrome, and scleroderma. And you can see compared to healthy control, you do see some interferon activity in Sjogren's and scleroderma, but really lupus takes the cake. And we see a lot of patients with circulating interferon signatures and increased interferon production. And these interferons come from both the innate immune cells in our body, macrophages, dendritic cells, plasmacytoid dendritic cells, but also are produced by the tissue. So the keratinocytes, for example, in the skin are very good at producing type 1 interferons. And these interferons are driven by what we know cause lupus flares, like UV, viruses, and bacteria. And the reason that these interferons are important is because they cause widespread changes to the immune system. And they do things like making our dendritic cells more active to present antigen to our T cells. They increase class switching of our B cells and get them to make more antibodies. They repress the negative regulators in our immune system, like the Tregs, and keep them from turning off inflammation when it gets started. And they're also really important in driving the development of lupus rashes. So the interferons are kind of a unique thing that get turned on sort of simultaneously with these triggers, and they really impact both the innate and the adaptive immune system. And I think when we think about the biology of how we treat lupus flares, one of the things that's very cool about treating lupus now is that we have a drug that can block interferon signaling called anifrolumab. And this is just data from one of the trials for anifrolumab that shows that patients who were on anifrolumab actually had fewer flares while they were on treatment. And so again, the type 1 interferon activation may also be playing a role in activating this whole flare process. And really, I put this here as a pro tip because right now we still don't have a very accessible way to test for high interferons in lupus patients, but you can get clues just from lupus patient phenotypes. So if they have a lot of antibodies to RNA proteins like Smith RNP, RA, they tend to have a higher interferon signature in general when they carry these autoantibodies. Patients who are refractory to Plaquenil often have more interferon circulating. Patients who have very low lymphocyte counts often have a higher interferon presence as well. And then again, patients with skin disease often have a very robust interferon signature, both in the skin and in the circulating blood. So if you're thinking about what patients to give anifrolumab to, and you don't have a test for looking for interferons, and someday we may, this is one way to kind of decide if the patient might benefit from something like anifrolumab. So the third point I want to raise is that T cells are important, but aren't the only player in lupus flares. I think 15 years ago, we were very T cell centric in lupus. And now we know that the innate immune system also plays an important role. But some of the things that happen in lupus with the T cells is that we really don't have very good regulatory T cells in lupus patients. So we don't have this off switch to turn off the inflammation. And there's been trials that have tried to turn this on. So far, we haven't been able to get this to work yet. We also know that the T cells are more activated in lupus patients, and this provides B cell help, which allows for B cells to mature and class switch and make more autoantibodies. We also know that in lupus, there's increased cytotoxic T cells in the organs of patients, and this causes cell killing and tissue damage. So if we think that a patient's having a flare and that the T cells are activated, drugs like methotrexate and Cellcept are really good at coming in and stopping the replication and activation of T cells. The fourth thing I wanted to discuss is that B cell activation is really important in many patients. And we develop autoreactive B cells for several reasons, but one of the reasons that our B cells can escape negative selection is that there's a protein called BAFF that allows for B cells to survive even if they're recognizing autoantigen during the selection process. And in healthy people, the BAFF levels are pretty low. And in lupus, we know that the BAFF levels go really high. And actually, as an aside, the interferons actually can make those BAFF levels go up. So if you have a lot of BAFF floating around and you are trying to delete an autoreactive B cell during its development, you will override that death signal through the signaling through the BAFF receptor, and you actually will let those B cells survive. So as you likely know, we now have a drug that blocks BAFF called belimumab. And belimumab is one of the things that it does is it prevents this survival of these autoreactive B cells. And also, if we look at the developmental pathway of B cells in general, you can see that the BAF signaling is important in these very early B cell stage development. And once patients get not patients. Once the B cells get to a more mature stage, the BAF plays less of a role in the activation or maturation of these cells. And so I think another pro tip is that you really, when you give a patient belimumab, it takes a long time to work. Because it's not eliminating the cells that are currently making autoantibodies, but rather it's working on preventing the development of these autoreactive cells early on. So oftentimes, if you're treating a flare and you're thinking about adding belimumab, you really need to add in a quicker acting medicine with the belimumab in order to shut off the active part of the immune system and then wait for the belimumab to work by preventing the development of these cells down the road. So steroids plus belimumab can be a combination that you can think about. And B cell active, so I have a second slide here. I'm kind of breaking my 5-slide rule, but I wanted to also emphasize that the autoreactive B cells that turn into antibody secreting cells, there's actually different antibody secreting cells that contribute to different types of autoantibodies. So you may have heard about plasmablasts, which are sort of rapidly made after a naive B cell gets activated. It turns out that plasmablasts, or sometimes you'll hear them called short-lived plasmablasts, are actually really good at making anti-DNA antibodies, and also antibodies that bind the MDNA or the NMDA receptor. These antibodies can activate complement and cause immune complex deposition in tissues. But because more of the DNA antibodies are coming from this, if you use a drug that targets a plasmablast, you might have a better impact on these types of antibodies. Now, the RNA antibodies come from long-lived plasma cells. So if you're using a drug that doesn't deplete a long-lived plasma cell, but the disease is being driven by anti-RNA focused autoantibodies, you might not get as much of a treatment benefit from that. And so if you think about another pro tip for treating lupus, belimumab actually probably has more effects on phenotypes that are coming from short-lived plasmablasts, because it can affect the development and block the development of these plasmablasts. The long-lived plasma cells that stick around forever, they're not going to be killed off by belimumab. And so if you're targeting a disease related to antibodies produced by these long-lived plasma cells, belimumab might not be the best drug to choose for that patient. The other thing to remember is that rituximab also doesn't deplete most plasma cells. And so again, if you've got a patient that you think is having trouble because they're making all these RNA antibodies and RNA-driven immune complexes, rituximab may not help here. But again, if they're having things driven by short-lived plasmablasts, then maybe Rituxan would be useful because it's going to help deplete those. And the other thing to remember is that coming down the pipeline, there's a lot of therapies in development that actually will take out both populations of these antibody secreting cells, including CAR T therapy. So CD19 CAR Ts will deplete populations of both of these groups. And so, that may be one of the reasons why, a more holistic B cell targeting therapy could be more effective. But for now, those are still in, the research space. And then the last piece about lupus biology and lupus flares that I wanted to highlight was that complement activation is an important part of how tissues become damaged in lupus. And so, we all maybe remember or maybe have to look up every time we think about it when we think about complement activation. But I think the important things to remember is that the reason this is important is because you get immune complexes in the kidney, which can activate the innate, or the kidney, using the kidney as an example here, you can activate innate immune cells that are triggered by these immune complexes that build up in the organs. But also as complement is activated, it also produces chemotactic factors that can bring inflammatory cells into the organ. So it's not just the immune complex itself, but it's the activation of chemotactic signals that also contribute to disease. And we know that a lot of manifestations of lupus, including nephritis and skin disease and arthritis and CNS lupus and pleurisy and hemolytic anemia, they all have demonstrated roles for immune complexes in causing, destruction or disease in these various organs. And so immune complexes are important, and complement activation is part of that. And if you think about when the complement gets activated, one of the pro tips is the reason why we see a low C3 and C4 is because these C3 and C4s get cleaved as part of this complement activation pathway. And so if you measure the total C3 or C4, it's going to go down as these are getting cleaved into their byproducts. So that's why that test works when we're trying to see if a patient has disease activity.
All right. Thank you so much, Michelle. That was fabulous. I gotta love her style and her presentation, especially the pro tips. I mean, that's just, she explains the biology and then she hits you with a pro tip, and you gotta love it. Again, if you want to hear the rest of her, another 15 to actually, I think about 16 more minutes of her talk where she's talking about therapy and the EULAR guidelines and how it relates to management of flares, you can see that on YouTube and also on RheumNow. Again, I think that the rules on, or the suggestions as to who may have a high interferon signature and who may need anifrolumab, refractory to hydroxychloroquine, lymphopenia, skin disease, and multiple autoantibodies. Ooh, that's a really good tip, because honestly, do you really know who to use anifrolumab, or for that matter, rituximab or belimumab in? It's, we need good rules. What we do know about anifrolumab is it works really, really well on skin and joint disease. And it may be for the reason she just stated, that this may be the high interferon state. And those organs may be more dynamic to the influence of interferon alpha. And that's why they may work really well. That was a sub-analysis of the registration trials done by Joan Merrill that we presented before, coming out of, I think, EULAR 23 and maybe even 22. So that was a great presentation. Now we're going to end. Again, if you have any other questions to end the session, put them in the Q&A box. Our final session, our final lecture is from Andrea Fava, sort of a part of the Michelle Petrie lab at Hopkins. Dr. Fava has been working there a long while and does some great work on biomarkers, especially urinary biomarkers in SLE patients and their predictive value. In the beginning of this lecture, I'm going to begin about 3 minutes into the lecture. He goes over why proteinuria is a lousy measure, why there are difficulties with biopsies. While he does point out that up to 80+% of patients will have a change in treatment as a result of biopsies, getting biopsies, interpreting biopsies, not having serial biopsies are problems. That, and again, what do you base your treatment on? Their symptoms, their serologies, their proteinuria, and maybe a biopsy. Well, a lot of that is in fact poorly predictive, which is why we asked Dr. Fava to address the issue of really future management of lupus and the use of biomarkers. Listen up.
So we need better biomarkers, especially if they are tied to pathophysiology. They can tell us if they reflect tissue biology, they can guide treatment in real time. So this was how we tackled this issue. We developed this proteomic pipeline in which we took more than 200 patients with lupus nephritis at time of diagnosis, and we got a urine sample before diagnosis. And then again, after 3, 6, and 12 months of treatment, and we quantified 1,200 urinary proteins to find biomarkers of disease. Urine, because it's downstream of the kidneys, and it collects information from both kidneys, not just a little piece of tissue that you get with a kidney biopsy, is the ideal specimen to actually sample the biology of the kidney. So the first question we asked was, what are the proteomic signatures of the different lupus nephritis classes? And just to remind everyone, we can oversimplify kidney histology into 2 major groups. Proliferative, which are the class 3 and 4. It means that there is more inflammation inside the glomeruli, more aggressive, higher risk of damage over time. and membranous at the bottom, where you have thickening of the glomerular basal membrane, more pink, and less inflammation inside the glomeruli. So the first thing we ask is that, okay, well, let's compare proliferative versus healthy just to get the baseline. So this is a volcano plot. Each dot is a protein. If it's on the right, it means that it was enriched in the urine of patient with pure proliferative disease. If it's on the left, the comparator is healthy control, so it means it was lower in lupus. The y-axis is the negative log of the p-value, so the higher, the more statistically significant. So all the proteins you see within that circle are the proteins enriched in proliferative lupus nephritis. And to make biological sense, we did path enrichment analysis, and we found that leukocytes, so inflammation, cellular inflammation, neutrophil degranulation were the pathway enriched, not surprisingly, in patients with more immune infiltration in the kidney. But we also found evidence of extracellular matrix disassembly, suggesting that we can measure in real time ongoing damage to the kidney. Let me just skip this one for sake of time. So then you say, well, sure, lupus patient and proteinuria, they have a different signature, but let's go to the important question. Can you separate lupus like +4 from +5, for example? So, and this is a comparison of any proliferative lupus nephritis, so +3 and 5, 3 and 4 versus the others. And this is the signature that was specific to the patient with proliferative disease. And there were a few biomarkers, such as interleukin-16, CD163, that were kind of famous and important. But all the protein that you see circled in red, these are found inside the granules of neutrophils. And pathway enrichment analysis showed that neutrophil degranulation was the main signature that characterized lupus nephritis. So what is the signature of histological activity, which is the number that goes from 0 to 24 that we kind of value when we get the biopsy back? We wanted to see if there was a dose response to this effect. And these are two volcano plots. This time are showing the correlation with the NIH activity index. So the proteins in pink and on the right are those that positively correlate with histological activity. So the higher inflammation in the inflammation in the kidney, the higher the concentration in the urine. And in these two cohorts, interleukin-16 came out as the protein that most correlated with histological activity, and that was followed by CD163 and many others. So the many others, and I'm sorry this is not showing correctly, but the many others were again the neutrophil granules, so the protein that we found in neutrophils, and pathway enrichment showed the neutrophil degranulation was the main signature correlating with activity. And that you see at the top is PR3. Wait a minute, I know PR3, I've heard that before, but it's in a different disease. What is it doing here? And so we said, well, let's go and take a look. And then we looked at, this is a biopsy of a lupus patient, and we stained for PR3 and MPO, and then we were mesmerized. It lighted up as a starry night, and we found plenty of these cells in the kidney. So we are now studying them to see how can we target these cells, because clearly they correlate with activity, and clearly we can do something about it because they're causing damage. All right, to summarize the first part, urine proteomics can detect active biological pathways in nephritis, and pure membranous and proliferative, I didn't show that, but they both share a signature of matrix remodeling, telling us that even membranous, that we think is more benign, actually is affecting the kidney in a structural way. Active proliferative lupus nephritis is characterized by neutrophil degranulation, and interleukin-16, which is a pro-inflammatory molecule, is linked to lupus nephritis, and it is a potentially new target, and is also a promising biomarker. So I'm a clinician. So like you, I want something that I can use in practice. And so we asked, I really want a biomarker that could predict if the patient in front of me is going to respond to treatment, and even better, to which treatment. And so we asked, which are the protein at baseline that can predict response? And what a disappointment. There was nothing, zero, flat line. It couldn't be more negative than this. So these are the proteins on the right that are increased at baseline in patients who would respond in 1 year, and on the left, those who in the non-responders, there was no difference. And so we started thinking, well, some of my patients are responding to treatment, some other are not responding to treatment, because I know at 1 year they're going to do better. And so, and we are giving them immunosuppression. So that immunosuppression is doing something. It must be perturbing the system in the kidney, and we should see a biological response to that. And so we said, well, listen, let's look at 3 months. Let's look at what has changed in the people who eventually will respond to treatment as compared to those who did not respond to treatment. And this is what we found. We found that in the patients who ultimately were classified as non-responders, there were no changes after 3 months of treatment. But in those who eventually responded to treatment, there was a significant reduction in a number of proteins that are those indicated in pink in the graph on the right. And if you remember, these are the same proteins that are correlated with histological activity. And this is telling us that the effective immunosuppression is reducing histological activity, which is resulting in this mirrored reduction of these proteins of inflammation in the urine. And that can be measured in real time. And we can predict at 3 years, at 3 months, who's going to respond at 1 year. And are these good biomarkers? Now, this volcano plot here is plotting now the AUC, the area under the curve, which is a measurement of how accurate a predictor is. And this is at 3 months, the ability of these biomarkers at 3 months to predict response at 1 year, as compared to UPCR, so urine protein to creatinine ratio, which is our gold standard. And all the proteins in the blue circle are those that are outperforming proteinuria significantly. So we don't need a biomarker to just be as good as proteinuria because that will be useless. But now we have potential biomarkers that outperform our gold standard. So to summarize the second part, a decline of 3 months of urinary biomarkers of immunological response now best predicted 1 year response, especially in proliferative lupus nephritis. And treatment response is paralleled by a decrease in activity-associated signature. I didn't show that, but the signature of the granulation and matrix disassembly went down. And because these biomarkers of immunological response parallel intrarenal activity, they could detect early treatment responses and failure and then allow early treatment changes. These have an important role as surrogate endpoints in clinical trial, and I'll tell you more about that. Because the natural question becomes, should this biomarker now be the new treatment endpoint? Who cares about proteinuria if I have something better? So right now, the response in lupus nephritis is proteinuria-centric. And if you look at some examples in major trials and in the guidelines, they all hinge about, they focus on a reduction of proteinuria below a certain threshold after 3, 6, 12 months, or 24 months. And there's a good reason for that. So Maria Delaire a few years ago took the patients from the EuroLupus trial and looked at the patients who at 6, 7 years still maintained a creatinine less than 1. And so she asked, what is the proteinuria threshold at 1 year that best predict preservation of kidney function at 7 years? And what she found is that more or less 0.7, 0.8 is the best threshold for sensitivity and specificity, which is the rationale of why in the belimumab, in the Blisalan trial, the goal was 0.7. But we just spent some time at the beginning showing how proteinuria is a very inaccurate measurement of response, meaning that a reduction in proteinuria does not correspond to a reduction of inflammation in the kidney. So what do we do when our gold standard is not that golden, when we have a bronze standard? And so we started thinking about, listen, we treat patients not to improve the proteinuria number. We treat lupus nephritis patients because we want to save their kidneys. We want to preserve their kidney function. We don't want this young girl end up on dialysis. And so we looked at the trajectories of their kidney function. And these are the trajectory of the kidney function of the GFR starting at 1 is normalized to basically everyone started at the same starting point in the lupus cohort. And over 5 years. And we found 2 groups of patients. One group that over 5 years, starting at the time of kidney biopsy, maintained their kidney function. And there was one group on the right that progressively lost kidney function. And what was shocking to learn is that 1/3 of the patients who at 1 year were classified as complete responders continued to accrue progressive renal damage, meaning that they were in the second category. So even our definition of complete response is not a good predictor of preserving the kidney. And so we wanted to apply this concept to our biomarker study with the idea that let's find out now at 3 years who has maintained the kidney function and who has lost kidney function as a consequence of lupus nephritis. And let's see if our biomarkers can give us a better answer than proteinuria. And so we looked in a cohort in the proteinuria cohort, and we were able to replicate the findings. We had a significant amount of patients that lost the GFR at 3 years, defined as either developing end-stage kidney disease, needing a kidney transplant or dialysis, or losing more than 15 ml of GFR in 3 years. And this is like data that are still coming in. So by now we have 92, and we had 36 patients that met the criterion of GFR loss at 3 years. And look at the bottom. 22% of patients that ended up losing significant kidney function were classified as complete or partial responders at 1 year. And so the hypothesis that we wanted to test is, if I have a biomarker of inflammation, of immunological activity in the kidney, in the urine, and my hypothesis is that the patients who lose kidney function over time lose it because I don't treat them good and well enough, and there is persistent inflammation in the kidney that is, chewing on that matrix and is causing damage. Therefore, I would expect to see that after 6 or 12 months, there is persistent elevation of biomarker of histological activity. And so this is what happens with proteinuria at 6 months. So the group on the right is the group that lost GFR, the group on the left with the one with the stable GFR, and proteinuria had some predictive ability. But this is what happens with the other one. So for example, interleukin-16, I just want to point out the AUC, the area under the curve, the maximum is 1, and it had a 83% prediction of the correct outcome at 6 months. But look at 12 months. At 12 months, proteinuria had an AUC of 76% as compared to an AUC of interleukin-16 of 88%. Is that something clinically meaningful? So this is comparing directly the performance in terms of sensitivity, specificity, PPV, NPV, and accuracy of interleukin-16 and proteinuria at 12 months. Sensitivity is much higher, specificity is higher. Positive predictive value, negative predictive value, which is what we care about in the clinic, are significantly better for interleukin-16 as compared to proteinuria. The accuracy, which is how many times you guess it right, was 92% for interleukin-16 and 72% for UPCR. That means that when you make a prediction based on interleukin-16 at 12 months, you get the right prediction, you get the wrong prediction 88% of the time, whereas when you use proteinuria, you are wrong 28% of the time, so 3.5 times more often. As clinician, we really like when we are right, but we really hate when we are wrong about the patient. And so if you look at the misclassification rate, you can see how a biomarker like this could really change the conversation and our ability to make the correct prediction. And of course, we want to combine them. This is nowhere near anything final, but just for, to show friends and impress people. When you combine the 3 biomarkers together, the area under the curve is 96%. But we are working on a biomarker panel that could really be applied in practice, hopefully soon. So to summarize the last part, elevation of biomarkers of histological activity after 6 or 12 months of treatment predicts GFR loss at 3 years better than proteinuria, especially interleukin-16. So insufficient immunosuppression likely results in persistent intrarenal immunological activity leading to kidney function loss. And because the ultimate treatment of lupus nephritis is long-term preservation of kidney function, clinical trial endpoints should include response definitions that best associate with GFR preservation, not just an improvement in proteinuria. And
Okay. That's an amazing lecture. I think that obviously they got it going on at the Hopkins Lupus Clinic, where they continue to be not just great teachers, but great researchers in this area. So you might ask, where can I get IL-16 and CD63 and these other biomarkers are not commercially available in most places yet, but they will be probably within a year, if not 2 years, that they can be incorporated into your clinical management. And I would strongly, I know I'm looking forward to incorporating them into my decision-making on lupus patients. It really is a black box sometimes in making those decisions. We have a few questions. One going back to Dr. Michelle Kahlenberg's talk, where I'm asked, how would you classify a patient as being hydroxychloroquine refractory, since most patients are also on another DMARD on top of taking hydroxychloroquine? Well, that's actually not entirely true. Number one, almost all of you put all lupus patients on hydroxychloroquine, often as a first and early step. And there's a significant number of people who are on hydroxychloroquine by itself. I think my definition of refractory when they're on hydroxychloroquine is one, that they have symptoms and activity, especially skin and joint, despite being hydroxychloroquine. The second definition would be the need to escalate or introduce steroids to control symptoms. And lastly, the need to add on a DMARD, and that would be the definition of hydroxychloroquine refractory. But remember, that was just one of 4 suggestions she had for the profile of someone who has a high interferon signature. The others, I believe, were lymphopenia, a multiplicity of autoantibodies, and what was the other one? And skin involvement, right? That's what she suggested. Another question from Dr. Vega. Luis, did you mean psittacosis or did you mean psoriasis? So in his question, he says, a patient who has, let's say, psittacosis, leukopenia, C3 and C4 that's decreased, but a negative ANA, would that be incomplete lupus? First off, you can't have lupus and you can't have incomplete lupus if you're ANA negative. I mean, that's part of the EULAR criteria. EULAR criteria for diagnosis begins with ANA positivity. Again, I think for us as uber specialists in lupus, we might be able to make a diagnosis of ANA negative lupus in the presence of multiple autoantibodies and in select situations. But really, that's a pre-1982 phenomenon. And we should not be talking very much about ANA negative lupus or ANA negative pre-lupus or incomplete lupus. If that patient you're talking about has psittacosis, psittacosis is parrot fever. I know about that because I've seen a number of Still's patients with high fevers be misdiagnosed as Still's when in fact they had psittacosis. And psittacosis as an infection could give you depressed complements and could give you even serologic positivity, but is not likely. I don't know of any association between psittacosis and lupus. On the other hand, if you wrote psoriasis with leukopenia, C3, C4 depressed, there are cases of psoriasis that does co-associate with lupus, but again, these should all be ANA positive. So I want to underscore what I think Dr. Karp said in his lecture, which is a criterion for having preclinical lupus, stage 2, stage 1 lupus, is ANA positivity for stage 1. ANA positivity with or without other autoantibodies and something else, that would be stage 2, but not enough to give you criteria or meet criteria, the old criteria, the new EULAR criteria. And then once you meet criteria, then you got stage 3 lupus. Stage 4 would be burnt out lupus. Let me end with I think there are no more questions. Let me end with a review of our survey questions from this past week. That is a one-day survey. We got a fair number of good answers from you. And here we go. So this survey, which went out yesterday, and 172 of you answered the survey. Here's a few questions. What percentage of lupus patients experience a flare in each year? 51% of you got it right, 25%. That was indicated both by Dr. Karp and also by Dr. Kahlenberg in their lectures. And again, you can see the answers to these by clicking on it on RheumNow. It's on the homepage on the email. You can click on this, see all the answers. Second question, type 1 interferons play a significant role in lupus flares and can be targeted by treatments like anifrolumab. Absolutely, the right answer here is true. And 94% of you got it right. Again, as she suggested, interferons can be driven by innate immune responses generated by infection, generated by photosensitivity, by PAMPs and DAMs, pathogens, and damage. Associated molecular patterns. Third question is, the 2023 EULAR recommendations for the management of lupus suggest that hydroxychloroquine be given to all patients. All but 1% of you got that one right. And that's sort of I think, part of the Bible of managing lupus as we do. 3 more questions. An SLE, proteinuria is a reliable indicator that correlates well with lupus nephritis. 45% of you said yes, but thankfully more of you, 55%, said no. And that was pointed out in the first 3 minutes of Dr. Fava's lecture. If you want to hear Dr. Fava's lecture in its entirety, it's a podcast. And you can listen to it on the RheumNow website or on any podcast channel where you find the RheumNow podcast. Next, in lupus, urinary levels of IL-16 and CD63 have been confirmed to be urinary biomarkers most correlated with histologic activity on renal biopsy. The answer is right, and 81% of you got that right. The last question is, repeat kidney biopsies often lead to a change in treatment. That was covered by Dr. Fava early in his lecture, where he said 87% of people who have a repeat biopsy will have a change in their treatment. But again, as he pointed out, there are limitations to using a renal biopsy. Not many of you do it all the time. Academic centers are more likely to do it than non-academic centers. Anyway, that's it for this series of replays from RheumNow Live 2024. RheumNow Live 2025 is going to happen on February 8th and 9th, and we'll open up registration for that this summer. There are benefits to participation. One, you get all the content all the time. You get a lot of content immediately after the meeting that reviews what you learned in your 2 days at RheumNow Live in Dallas or online. We generally have about 1/3 or so, 30% of our audience attend in the meeting. That's about, we're looking at about 150 people, 170 people max in Dallas. And then online, we have 300 to 400 people who are tuning in online. If you are a registrant, if you register for the meeting after June 1st, you'll get board questions from the meeting for 2025. We'll also send you the board questions for 2024. So we hope to see you at RheumNow Live in February 8th and 9th, 2025. Thanks very much for tuning into this series. If you have suggestions on what we can do better at RheumNow and or at RheumNow Live, please send me an email at jackcush@rheumnow.com. Maybe there's one more question. This is from Faisal Al-Mutarari. A patient with lupus fulfilled criteria with nephrotic range proteinuria pending a biopsy. Can we start pulse or 1 gram per kilogram until the result, or what about CellCept? Again, if you think the patient has nephritis, and I would base nephritis more on cells and hematuria in the urinary sediment, rather than the degree of nephrotic range proteinuria, or decline in renal function, yeah, I would pulse and then I would start effective therapy, which could be CellCept or the Euro protocol for cyclophosphamide or whatever it is that you like to do. Anyway, the great thing about questions like this, and the great thing about being a rheumatologist, if I had a really hard question, I didn't know what to do, I'd email, Dr. Kahlenberg or Dr. Karp or Dr. Fava and ask them their opinion. Everyone will, I find that we are, as a group, pretty tight, and like to share our certainties and or uncertainties with our colleagues. Thanks again. We'll see you soon on RheumNow.